Hi, Jerry. Can you hear me okay?
Now I can.
Absolutely perfect. We've got you back. All okay.
Okay, great. All right, let me continue. So automated subglottic aspiration systems, I'm going to speak about in the reduction of VAP and secondary lung infections in our ventilated COVID-19 patients. The presentation is going to talk about the impact of these secondary bacterial infections, the challenges that we face here in, particularly in New York, with respiratory therapists managing and coordinating ventilation care, the clinical-based evidence to prevent the VAPs, and the use of new technologies, particularly subglottic aspiration and prevention of these VAPs and bacterial infections. So here, when we do mechanical ventilation, one of the biggest harms and side effects that we face is microaspiration above the from microaspirated secretions above the cuff, and it results in secondary bacterial infections that are causing significant problems in the management of not only COVID-19 patients but also non-COVID patients. Dr. Fossey here talked about how during the Spanish flu pandemic that many patients died from aspiration of colonized secretions coming from microaspirated secretions coming from the upper airway tract into the sterile lower airway, causing the secondary bacterial infections. The rate of VAP during COVID here in the U.S., we're showing 51% secondary bacterial infections on top of 49% of the primary COVID pneumonias. This is causing significant problems, increased mortality and morbidity of these patients, and the inability of antibiotics to control these secondary infections. Many of the hospitals here, particularly in New York, report zero VAP, which is causing a problem because there's no incentive to control these secondary bacterial pneumonias because they're not reported. They're reported under ventilator-acquired events. One of the highlights from this paper, healthcare-associated infections, shows that VAE over the course 4 quarters of last year showed that nosocomial infections increased significantly over the 4 quarters on ventilated COVID-19 patients, primarily due to the secondary infections coming from the oral secretions getting microaspirated into the trachea, pooling above the cuff. Since we produce 1 to 1.5 liters of saliva per day in the mouth, the majority of it goes to the esophagus and gets swallowed, but there is approximately 20 to 30% that wind up microaspirated. What we try to do in our ICU is we add scopolamine. We try to medically control the secretions by adding scopolamine 1.5 milligrams transdermal patches. We also use sublingual optic atropine drops under the tongue to try to control the secretions. We also use scopolamine 0.12% oral care twice a day. The significant factors show that 45.2% of the death rate in our ICUs are primarily from VAP pneumonias. These secondary infections. We need to improve our VAP prevention strategies to improve patient outcomes. And this can be done through controlling cuff pressures, which you'll see in a future slide. Our 5-step VAP program, we increased to a 6-step VAP program, which includes head of the bed, semi-Fowler, high semi-Fowler, oral hygiene, hand hygiene as well. And we also have eliminated nebulizer treatments in the circuit to further reduce introducing bacteria. We switched all patients to metered-dose inhalers. The regular ET tubes and trach tubes we've eliminated, and we have implemented subglottic aspiration systems. These are Mellencrot tubes primarily, and Portex blue line subglottics. And what we have found that whether we use the endotracheal or the trach tube, the results are the same. We've found significant pooling of secretions above the cuff in both of these patients. The issue is that these pooled microaspirated secretions wind up seeping around the cuff and down into the sterile lower airway. And I've heard respiratory therapists and pulmonologists talk about how they remove these secretions via 12 and 14 French suction catheters. I have yet to see this done. In essence, what would be required would be intubating the patient with a 14 French suction catheter. And when I hear this, I'm always very interested in seeing this done. I have yet to see it done. So what this results in, if we don't remove these secretions, is longer stays in our ICUs, much higher mortality rates. It's a huge challenge for the respiratory therapists who manage these patients, intubate these patients, manage these patients, because respiratory therapists here in the States, particularly in New York, are in very short supply. And you might have a single respiratory therapist that has 20, 25 ventilated patients, especially last year during the height of the COVID in New York City. So we need a better system to manage these patients to further reduce these secondary bacterial infections. The cost to the facility for these secondary infections range anywhere from $19,000 to $80,000. And that includes the antibiotics, that includes the extended DRG stays, the diagnostic related groups. It also includes the fact that the bed is occupied. So we don't have a turnover, we don't increase revenue. So what's the ideal solution? To effectively manage the secretions. We start with the medical management, the medicine management, scopolamine, the atropine, and switching to the subglottic aspiration systems. What we found is that once we apply our new 6-step VAP bundle, we get faster weaning results. Patients go on sedation vacations when they come out of CT-ICU or med-ICU. They're more awake and they have quicker recovery times. We use much less antibiotics, particularly in the long-term care setting. We have less tracheal suctioning, which reduces potential trauma from the lower airway tissue. We have less time in the ICU, and we reduce overall costs, and we reduce use of our resources. So we believe VAP is preventable in both hospital acute care and in long-term institutions by effectively managing the secretions. We believe the root cause of secondary bacterial infections is the microaspirate that seeps past the cuff and into the lower airway. So if we remove it, we remove the potential for these secondary infections. So here is Mellencrot subglottic aspiration system, the trach itself. As you can see, the secretions, microaspirated secretions pool above the cuff, eventually seep around the cuff, and cause these secondary infections. So here is a diagram of a paper I published, and it's 9 published RCTs since 1992. And what it is an average reduction in VAP using both manual syringe drawn and continuous wall suction or intermittent suctioning. So the highest rate of secretion withdrawal comes from the syringe. However, as you'll see in a future slide, the syringe is also the most dangerous. When you pull back, we measured pulling back on a 20 cc syringe, and we actually recorded minus 720 millimeters of pressure, which is approximately 4 to 5 times greater than the AARC recommended of minus 80 to minus 120. So while it's more effective, it's also more dangerous. The reason being, the subglottic aspiration trachs have a posterior subglottic port that suctions the secretions out, is a port open for suctioning secretions out of the airway. So being in the posterior section of the tracheostomy tube, when you draw back at minus 720, you run the risk of the posterior port adhering to the tracheal wall. This will cause significant damage, bleeding, and it is very uncomfortable for the patients. So the challenges to this actual suction device is wall suction is generally minus 20. It may be too low due to the viscous secretions. It's continuous, which means that you have an increased risk of the posterior port adhering to the tracheal wall. The intermittent may go up to 150 millimeters of mercury, but it's at a higher pressure, and it has short pulses, which might be not enough to draw out viscous secretions or high volumes. The manual, which we actually did in one of my RCTs, which I'll discuss, is very labor intensive. Respiratory therapists were going in there every 20 minutes, 40 to 45 minutes, having to manually suction this out, spending 15 minutes at bedside just to do these manual aspirations. The pressures are much higher than recommended, and we had significant adhesions to the tracheal walls, and that was evidenced by blood in the subglottic secretions that we suctioned out with the devices. Intermittent, you can tailor it. It prevents, you can also do it at reduced pressures. It's accurate, it's reliable, it's not manpower intensive, and it reduces the risk of adhesions to the tracheal wall with that intermittent suction. The VAP bundle, we expanded to include subglottic secretion drainage. So we have the head of the bed in semi-Fowler, 30 to 45. We do our daily sedation vacation. We add the ETT or the trach tube. We effectively use chlorhexidine with good oral care twice a day, or once every 12, or once every, we do it 3 times a day, once every 8-hour shift. We use proton pump inhibitors to reduce GERD and the risk of when the nursing assistants are changing the patient or doing daily care, where they lay the patient flat, and when we have the feeding that goes up the esophagus into the back of the oropharynx and get aspirated. So we also use 10-degree head of the bed for all daily care, and DVT prophylaxis, usually heparin, to prevent DVTs. The clinical experience we had, I did a random control study, IRB approved, 40-bed ventilator unit, 25 patients in the study group, 15 in the control group. Our optimal pressures, intermittent pressures, were minus 150 for 12-second durations at 10-minute intervals. The cuff pressures is significant to state because the normal cuff pressures on any cuff manometer is between 18 to 25. We increased our cuff pressures to 25 to 30. And what we found was that as we increased the cuff pressures, we also increased the amount of secretions that were pulled out of the subglottic space. So our respiratory therapists were using a technique called minimal occluded volume to reduce any tracheal malacia, tracheal stenosis from increased cuff pressures. But what we found was that as we increased the cuff pressures, we also increased the volumes. We followed up with tracheoscopy, and we found that there was no significant damage to the tracheal walls with the increase in cuff pressures to 25 to 30. When we compared the subglottic aspiration versus the syringe aspiration, what we found was that we averaged between 130 to 250 with the intermittent subglottic aspiration, where the syringe we only pulled 15 to 30 mLs. Our VAP rates during the study for a 4-month RCT was that out of the 25 subject study group, we had 8% VAP. We had 2 patients with VAP. In the 15 subject control group, we had a VAP rate of 33% or 5 patients. So the intermittent subglottic system in our long-term ventilated patients significantly reduced the incidence of VAP, significantly reduced the increased costs of antibiotics in these patients. It also had some significant side effect that we did not foresee in the RCT, and that was the decrease in maceration of tissue surrounding the stoma. It also significantly decreased the amount of time that was required for tracheostomy care because it reduced the soiling effect on the trach ties, on the 4x4s, and also the soiling of the patient's clothing surrounding the tracheostomy. The Cymix system, this is a diagram showing the connection of the Cymix system to the subglottic. An endotracheal tube can also be used. You would set the suction pressure, the interval and duration based upon the amount of secretions and the viscosity of the secretions. Also to note that when we, during this study, we did not have any patients complaining of pain in their trachea or any type of uncomfortability due to any adhesions to the tracheal wall. We did have one case where we had a tracheostomy tube that was too small. So the tracheostomy tube moved forward in the trachea, and it caused one adhesion. And we determined that through mild blood in the subglottic secretions. So the benefits of using the SSD with endotracheal and trach tubes is we have weaned patients off 2 to 3 days sooner due to the decrease in the secondary bacterial pneumonias. We freed up beds in the ICU due to less time on antibiotics and less time when we have a patient that has a secondary bacterial infection. We don't continue weaning due to increased oxygen demand and CO2 production. So when we free up the bed, we decrease the secondary infections. We can get the patient out of ICU into the step down sooner. Less use of antibiotics, we decrease cost, shorter time to rehab, and then shorter time from rehab to home. We use fewer resources, fewer vents, fewer respiratory therapists where they can be used in other places in the facility, primarily emergency room, and out of our step downs and into our ICUs. We improve the quality of life for the patient, faster weaning, less time on vent, and decreased time to decannulation or extubation. So we have less time for the clinicians caring for the patients, particularly in our ICUs, our COVID ICUs, when we have a 1-to-20 ratio for our respiratory therapists. And the hospital loves the concept because it decreases cost by approximately $40,000 per patient. Thank you.
Jerry, can you hear me okay?
I can now.
Absolutely brilliant. Thank you for the presentation and taking the time out to join us today. So yeah, we've got a couple of comments and insights we'll get shared. So thank you to Laura for kicking us off here. So Laura has mentioned on the unit that she works on, they use selective decontamination of the digestive tract, SDD. They tried that for years to try and reduce VAP. This involves antibiotic mouth swabbing 3 times a day to reduce infection rates. Question being, has something like this ever been tried within the USA?
I have not heard of this being done in any facility in New York City.
The
primary decontaminant is chlorhexidine, 0.12. It's usually done, it depends on the shift, sometimes once every 12 hours, if it's 12-hour shifts, or once every 8-hour shift, 3 times a day.
Perfect.
I haven't heard of bacterial swabbing, antibiotic swabbing.
Perfect. Moving on. Also, do you feel you face these problems because you need respiratory therapists to do these tasks? For instance, in the UK, the nurses do most, if not all, of the vent manipulations. What is your nurse's role in regards to the secretion management?
So, in the United States, most mechanical management of mechanical ventilation, arterial blood gas, art line insertion, intubation, extubation, trach changes are all done by the respiratory therapist. And that includes just daily maintenance, trach care, suctioning. In some instances where the respiratory therapist, there are fewer respiratory therapists, obviously the nurses do help out. In the ICUs, they will draw gases for them. In many instances, the blood gas machines are located in the respiratory department. So the nurse might draw from an art line and then give it to the respiratory therapist to run it. In many facilities, the respiratory therapist draws the gas, runs it, interprets the gas, makes the vent changes, and then notifies the pulmonologist. They work very closely with nursing. It's an interdisciplinary collaboration here.
Absolutely brilliant. Thank you, Jerry. I hope that's answered the question for you, Laura. Is the respiratory therapist an MD, Claire's asked?
No. In the United States, respiratory therapists some have associate's degrees, bachelor's, and master's degrees. They take 2 exams, a certified respiratory therapist, which would be roughly equivalent to the licensed practical nurse. And then you have the registered respiratory therapist, the RRT, which is the equivalent of a registered nurse in the nursing terms.
Yeah, absolutely perfect. Thank you, Jerry. Claire says thank you for that. And you have to bear with me for this one because I'm non-medical and I'm dyslexic, so this is going to put me through my paces here. How did you manage oropharyngeal secretions in prone patients? It's ORO. Do you know what I mean, Jerry? Yeah.
Yeah, so when we proned our patients, it actually was easier for us to manage the secretions. And that being because one of the primary issues in subglottic secretion management is if you sit the patient up past 50 degrees, because of the posterior port, all the secretions tend to move to the anterior portion of the trachea, which reduces and in many ways eliminates the effectiveness of the subglottic port. So what we found was that when we proned the patient, the secretions actually came up through the trachea and into the back of the oropharynx. And we could eliminate it that way. The subglottic we literally turned off. It wasn't effective.
Perfect. Well, Jerry, absolute pleasure talking to you involved. Thank you for that. We've been asked about the slides. Are we okay to get the slides shared post-conference as well? Is that okay?
Absolutely.
Absolutely brilliant. Yeah, there's resounding thanks coming from the audience as well, Jerry. So really appreciate your involvement. And as mentioned, we'll work closely with you to make sure the slides are being shared afterwards as well. So thank you again, Jerry, and take care.
Thank you very much.
Cheers now. That was absolutely brilliant to have some international representation today. So huge thank you to Jerry for committing and getting involved in today's conference. Hope you're all still enjoying the content. Well over 100 of you still here, so really thank you for the time. Please do keep the comments and questions coming through. We're joined by the team over at University Hospitals NHS Foundation Trust, which is Homerton by Lucy